Dr. Cuthbert is here with us today, and she's a nurse practitioner with a PhD in oncology nursing, and her clinical practice is largely focused on follow-up care and symptom management, and she has a keen interest in survivorship issues. Dr. Cuthbert is an assistant professor in the Faculty of Nursing at the University of Calgary and the Cummings School of Medicine, Department of Community Health Sciences, and is an adjunct professor as well in the Cummings School of Medicine, Department of Oncology. She holds a Tier 2 Canada Research Chair in Patient and Family-Centered Cancer Survivorship and is focused on evaluating biopsychosocial health needs and health outcomes of cancer survivors. Her program of research includes patient-oriented research approaches, integrated health knowledge, translation strategies, qualitative research, and the use of administrative data sets. So Dr. Cuthbert's goal is to ultimately improve health and well-being in cancer survivors and their families and developing innovative approaches to survivorship care. So thanks, Colleen. It's so great to have you to present to our group today. So I'll hand it over to you.
Great. Thank you very much, Linda, for that introduction. And this is a topic that actually has many overlapping clinical practice and research endeavors for me. And I'm just going to share my slides before I forget. There we go. Hopefully everybody can see those. So I've worked actually as a nurse practitioner in the chronic pain consult service in Calgary for many years. And this includes the management of both cancerous and non-cancerous patients. And what I've noticed is that it's very clear how to manage chronic pain in non-cancerous patients. But with patients that have a history of cancer, the management of chronic pain is much less clear. And so I'm really hoping by the end of this presentation that you will agree with me that we need to rethink managing chronic pain and cancer. So before I start, I just want to do a land acknowledgement. I want to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, located in the heart of Southern Alberta, which include the Blackfoot Confederacy, which is comprised of the Siksika, the Piikani, and the Kainai First Nations, and the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta. So just some objectives for today. I want to review the acute, what is the difference between acute versus chronic pain. I'll review the current clinical practice guidelines. I'll talk about the treatments for chronic pain and also highlight where there are gaps in care, and then explore future research and clinical practice ideas. So I actually want to start by showing a video. I hope that this works. And this is actually a video that we have our patients who attend the chronic pain center. We ask them to watch this. So it's a very brief overview of the difference between acute and a chronic pain. And I understand that this is a very simplified version, but it just gives you an idea of a place for us to start for this topic. So as I said, hopefully this works.
Everyone agrees that pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed as well as they can be by 3 to 6 months. So ongoing pain being produced by the brain is less about structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and may be contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story. By stepping back and looking at all the things that were happening around the time the pain developed, many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last, but by no means least, is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain does not protect by pain is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So, get a helping hand if you need it, set a goal, and begin.
All right, so hopefully that was a good overview. As you saw, that was geared towards a general audience, but a lot of those same principles, I would argue, apply to chronic pain and cancer. And so again, before I go into some of the research on this area, I just want to start with an overview of pain pathophysiology. Again, this is probably a very basic review for most people in the audience, but it's really just important to understand pain pathophysiology in order to distinguish between acute and a chronic pain. So this is a diagram of the pain signal pathway. And as you can see here, I also want to point out these blue boxes here demonstrate where medications work on the pain signaling pathway. So typically what happens is there's a stimulus to the nociceptors or the pain receptors. That stimulus can occur. So those nociceptors are in many parts of the body, and the stimulus that can affect those nociceptors are various. So they include things like heat or pressure or chemicals from damaged tissues. And when those nociceptors are stimulated, they send a signal along the nerve fiber to the spinal cord. Within the spinal cord, the pain signals are modulated and then relayed to the brain. And that's using specific pathways. The pain, the way the brain processes those signals is through various structures within the brain, including the thalamus, the somatosensory cortex, and the limbic system. And those are involved in processing and interpreting the pain signals, which is really important. Within the brain itself, pain signals can be modulated. Again, this is really important to think about when we're treating pain. So the perception of pain is modulated by various factors, which include neurotransmitters such as serotonin and endorphins. And those neurotransmitters can affect the descending pathways and either amplify or inhibit the pain signal. Also important to highlight that exogenous opioids, or opioids that we take, act in the same way as endogenous endorphins. And then we also need to think about psychological factors. So things such as stress, anxiety, and depression, which are processed in our higher brain functions, those can influence our perception and our experience of pain. So these psychological factors can interact with the physiological pathways involved in pain processing and lead to alterations in our perception and our experience of the intensity of pain. So how do we classify pain? So very broadly, pain is classified as either nociceptive or neuropathic or nociplastic. And I'll explain just briefly what each of these mean. So nociceptive pain, as the name indicates, it comes from stimulation of those nociceptors and those nociceptive pathways. And this is kind of the classic pain that you all think about, or you might think about. So things like damage to our soft tissues, damage to bones. So when you have a broken bone, or visceral pain, so if there's inflammation or damage to the internal organs. And if you're dealing with patient populations, they would describe this pain as dull or aching or throbbing, sharp or cramping. Neuropathic pain is different from nociceptive pain. Neuropathic pain can arise from damage to nerves, and that produces nerve pain. And damage can occur from various mechanisms. Neuropathic pain, though, can also arrive when there's abnormal processing of brain signals or pain signals within the brain. And we can have different responses to that abnormal processing. So we can have heightened response to stimuli, which is called hyperalgesia. We can have a pain response to something that would normally not be painful, which is something called allodynia. And a classic example of allodynia is when patients have pain in their foot, for example, when a blanket touches their leg. These changes in the central nervous system, such as neuroplastic changes, can contribute to the development and also the maintenance of neuropathic pain. So neuropathic pain can be an abnormal signaling within the nervous system itself, even in the absence of tissue damage. And then nociplastic pain is a relatively newer term. Some people may recognize this as central sensitization. Nociplastic pain is pain that is ongoing from altered nociception, but there's no tissue damage or inflammation that is propagating that nociceptive signal. Nociplastic pain is characterized as that kind of chronic diffuse, widespread, or poorly localized pain. And a classic example of nosoplastic pain is the pain that patients with fibromyalgia would experience. So what are the very broadly and generally the types of pain? So there's acute pain that lasts 3 months or longer, like they talked about in that video. And then there's chronic pain that lasts longer than 3 months. There are subtypes within each of these acute and chronic pain, but for simplicity, I thought I would just show you these two types. If you're very interested in this topic, you can look at the International Association for the Study of Pain, and their website actually lists the subtypes of those pain. So then how do we define chronic pain? So chronic pain is pain that lasts beyond the usual course of acute injury. It persists for longer than 3 months, and it severely and adversely affects an individual's well-being. It may become the sole or predominant clinical problem. So in some patients, chronic pain is the problem. It's not an underlying pathophysiological problem. And so, as you can imagine, for some patients, that's actually very difficult to reconcile, because what that means is there's not an easy fix to something that is causing their chronic pain. So, as they said in the video, just having surgery isn't going to fix the problem. And chronic pain is multifactorial, and it includes those biopsychosocial components. So this diagram here represents the biopsychosocial model of chronic pain. And again, this is really important to think about, because we need to address all of these potential drivers of chronic pain in order to manage chronic pain. So we have to think about mitigating or lessening those psychosocial factors, the social factors, as well as the biological factors. So that was just kind of a very general overview of chronic pain and cancer, chronic pain, but I want to move more specifically to talk about chronic pain in cancer and some of the research around this topic. So I'm sure most people are familiar with this infographic from the Canadian Cancer Society. This was from their 2022 special report on the prevalence of cancer in Canada. So we know that more than 1.5 million Canadians are living with cancer, and we know that the prevalence of cancer is rising. So this, there are a large number of people living with and beyond cancer. And we also know that cancer is now considered a chronic illness. With respect to chronic pain, it is highly prevalent in those who have completed curative intent treatment, with some research showing up to 40% of cancer patients have chronic pain. In one study, of those 40% that reported chronic pain, approximately 18% had pain that severely impacted their daily functioning. Chronic pain is also consistently reported as an unmet need in cancer survivors. And in a recent priority setting partnership study that was conducted by the James Lind Alliance, cancer survivors themselves stated that this was a top research priority for them. In some of our work, our team has done looking at some of our patient-reported outcomes, which are collected routinely in all of our cancer patients in Alberta. We have looked at the topic of chronic pain in various different populations. So this study was published in JCO Oncology Practice in 2023, and we looked at chronic pain in colorectal cancer, specifically in stage 2 and stage 3 patients who had completed treatment. In this study, which included, I can't recall, about 600 patients, about 600 patients were included in this study. We found that 40% of patients reported pain within the first 3 months of diagnosis. And importantly, about 25% of those had worsening pain after they completed treatment. We've also used these same patient-reported outcomes to look at pain across a variety of cancer types. And this is some preliminary data. We have just submitted this abstract to MASC, so this has not been published yet. We looked at all solid malignancies, but excluded hematological cancers, and in early stage cancer again. And we defined incident chronic pain as being a greater than 1 point increase in pain score compared to baseline that was sustained or worsened over 90 days. There was just over 1,500 patients in this study, as you can see, and about just over a third of them had developed chronic pain, with about half of those having mild pain and half of them having moderate to severe pain. So now just to switch to talk about some of the chronic pain syndromes that we see in cancer. And this is by no means an exhaustive list. This is just some of the ones that I thought might the audience might resonate with or might have had experience with. So chronic pain can arise from our cancer treatments, so including chemotherapy, surgery, radiation therapy, and immune therapy. And we know that this can cause tissue or nerve damage. And we also have to think about these cancer treatments can also exacerbate existing comorbidities, which may include chronic pain at baseline. So chemotherapy-related pain include chemotherapy-induced peripheral neuropathy. And sometimes peripheral neuropathy can be painful and sometimes it's not painful. So it's important to distinguish that. There's bony complications from being on long-term steroids. Most people are familiar with those myalgias and arthralgias that are associated with hormonal therapies. There's many radiation-related pain syndromes, including lymphedema and the plexopathies. Stem cell transplantation patients also have chronic pain syndromes, including arthralgias and myalgias, and they get something called a scleroderma-like skin changes. And then there's obviously a host of many surgical pain syndromes, including lymphedema, phantom pain, which would be a classic example of neuropathic pain, and then post-mastectomy pain. In addition to the kind of the biological basis of the reason patients can have chronic pain, we need to think about those psychosocial drivers, and there may be unique psychosocial drivers in cancer patients that we need to think about. So those include the fear of cancer recurrence, cancer distress, and pain catastrophizing. And Fitzgerald and colleagues did a study in 2023, and they actually demonstrated, it was a small study, it was only about 41 patients that completed a survey, but they actually demonstrated that pain catastrophizing was the most important psychosocial driver of chronic pain. And to me, that makes sense because pain for many patients can signal worries about cancer recurrence or worsening of cancer. So that pain catastrophizing really fits along with that psychosocial drivers. Again, as I stated earlier, we need to think about those existing comorbidities that may be exacerbated by cancer treatments, and those include chronic pain syndromes like low back pain, osteoarthritis, or fibromyalgia. So not only are there multiple drivers to chronic pain, but there are multiple impacts to the patient in multiple domains of having chronic pain. So we need to think about how pain impacts the physical domains, the spiritual domains, the psychological domains, their level of independence, which is very important. They're all important. And then social relationships. So we need to think about how these impact pain, but how pain impacts these domains in cancer patients. So what do we do about this problem of chronic pain, and how do we manage this for cancer patients? So there is 2 clinical practice guidelines that have been published, one by the American Society of Clinical Oncology. This was published in 2016 by Pace and colleagues, and this is basically an expert consensus guideline based on best available evidence. There also is a Society for Integrative Oncology guideline that was published, I believe, in 2022. It focuses on non-pharmacological management only and includes acute and chronic pain. So the kind of 2 guidelines to help us guide our practice. I'll just give you the highlights of those chronic pain management guidelines. So they state that comprehensive pain assessment should occur for any cancer patient experiencing pain at every visit that they're complaining or experiencing pain. That universal screening for risk of problematic opioid use should occur. That education about the risks and benefits of medications and other treatments should occur. Adoption of multimodal pain management strategies, including pharmacological and non-pharmacological approaches. That opioid tapering and or discontinuation should occur whenever possible. That we need to think about harm reduction and referral to pain management specialists. And so I will just highlight some of the areas in where I've done some research and my team has done some research. So I'm not going to be talking about all these points in more detail. Also important to note that chronic pain treatment goals are different than acute pain treatment goals. So we need to go beyond just relieving pain and enhancing comfort with chronic pain. We need to minimize opioid use, improve function, limit adverse effects, ensure safety, manage psychosocial stressors, and promote self-management. So let's talk a little bit about the role of opioids. This is, again, where my team has done some work. So opioids, as many people know, are the mainstay of treatment for moderate to severe acute pain or when we're dealing with advanced stages of disease. But their role in treating chronic pain is really not as straightforward for several reasons. The long-term efficacy of opioids in cancer has not been established. And in fact, most studies on opioids that have been conducted are only 6 weeks in length. Adverse effects are many with respect to opioids, and we need to consider those adverse effects when we're balancing harm versus benefit. There are serious harms associated with opioids, including accidental overdose, which happens more often than you would think. There's risk of patients converting to misusing opioids, and the older term for opioid misuse is addiction. Opioids may prevent people from returning to their pre-cancer work, including work and driving. And then there is emerging evidence of the negative impacts of chronic opioid use. So basically, we need to be cautious about using prolonged or chronic opioids, which means more than 3 months in length with cancer survivors, because of those myriad of adverse effects that I just talked about. Prolonged opioid use is actually proposed as one of the drivers of the opioid crisis. And that is because there is a risk with prolonged opioid use that people will convert, as I said, to becoming opioid misusers. The data for that in cancer is much more limited than in non-cancerous conditions. But again, it is proposed to be one of the drivers of the opioid crisis. There is also emerging evidence that their health outcomes may be impacted with chronic opioid use. So there has been some research to show that there's a greater likelihood of being hospitalized and visiting the ER if you're using opioids chronically. And there's also some evidence to show worse overall and disease-free survival if you're using opioids chronically. This is a study that our larger team conducted, and we looked at surgical patients, about 19,000. This was published in the Annals of Surgery. And what we found was that surgical patients who were persistent opioid users had higher rates of healthcare utilization, as you can imagine, as well as higher overall mortality and non-cancer mortality compared to non-opioid users. And sorry, that was published in 2023. And we know, so you're probably thinking to yourself, well, how many, is this even a problem that we need to think about? How many people are actually using chronic opioids in the cancer setting? So various people have looked at this problem, and there's actually a very good review that was just published in 2021 by Fitzgerald and colleagues, which is listed at the bottom here. So the prevalence of people that use of cancer patients that use opioids chronically, so meaning greater than 90 days, has been estimated to be between 5 and 45%. And of course, that varies by cancer type, stage of diagnosis, the treatments that they've had, and also how people are defining chronic opioid use. And so the standardized definition by the International Association on the Study of Pain is actually continuous use of 90 days or greater. There's some literature to suggest that chronic opioid use may actually be higher in cancer versus non-cancer populations. So this is a problem that we need to pay attention to. Our team did a cohort study that was published in 2019. It was a smaller study. It included 691 patients. And we did find 14% of those patients were chronic opioid users. And in the Lin et al. Study that was on the previous slide, of those 19,000 surgical patients, about 8% of those were classified as chronic opioid users. So again, it's hard to pin down exactly the number of people that are using chronic opioids, but there is evidence to suggest that this is a problem we need to think about. So our team actually is currently conducting a large CIHR mixed method study, CIHR funded mixed method study, really looking at this idea of opioid use in early stage cancer patients. And the overall goals of that larger study are to understand opioid use, prescribing practices, and also health outcomes. So we really are trying to understand this problem from an Alberta perspective. As part of that larger mixed method study, we have conducted qualitative studies with both patients and physicians. And our goal was to ask them about what they think about opioid prescribing in early stage cancer patients, but also what they think about some of these proposed safety measures that come from those ASCO clinical practice guidelines. And so this qualitative study with physicians was published in JCO Oncology Practice in 2023. And this included 24 clinicians in Alberta. So anybody that was an opioid prescriber was eligible to be included. And in general, what the physicians told us, or what the prescribers told us, was that they understand that you need to be more judicious in early versus late stage cancer patients when you're prescribing opioids. They actually didn't think that misuse of opioids was a problem at all that they needed to think about. They also didn't think that guidelines for safe prescribing applied to them personally. They said, oh, maybe other people, especially novice practitioners, but it doesn't apply to my practice. And they also didn't think that those safe prescribing approaches should be universally applied in the healthcare setting. We also did a qualitative study with cancer patients to ask them about taking opioids and how to safely promote taking opioids in the patient population. This is another abstract that has just been submitted to MASC, so the studies or the findings haven't been officially published yet. This included 16 cancer survivors. And we found their responses were so interesting and different compared to the clinicians that we interviewed. So what they reported to us was that their decision to start or continue opioids was heavily influenced by the negative impact that pain had on their quality of life, but also their past experiences with taking opioids. They stated that by and large, they had very little education about opioids from their prescribers, and that if they did ask for opioids, that often that led to this kind of strained relationship between their healthcare providers and themselves. There's often a loss of control and shame, and they noted those were barriers to taking opioids. What they did state was helpful was if often pharmacists were a great source of education for them, and that they found that involving their families was also really important in that ongoing decision-making process about opioids. Very interestingly, they all wanted very fulsome discussion about the potential harms and also the risk of misuse. So patients are very wary, by and large, about taking opioids, largely because of the heightened media frenzy about the opioid crisis. And they want to know what their risks are for opioid misuse. So it's important for providers to talk very frankly about that. Also in the chronic pain management guidelines that I'm not going to go into in detail, aside from opioids, there are non-opioid medications that patients can take. And the chronic pain management guidelines by ASCO outlines the evidence for these treatments. I will highlight that cannabinoids, although this is a hot topic and a lot of patients are wondering about the role of cannabinoids in managing their pain, in cancer in particular, there really is not great evidence to support the use of cannabinoids. So what about non-pharmacological treatments? How else can we manage chronic pain? So again, this is from those clinical practice guidelines. This is a table about the various disciplinary perspectives or types of interventions that can be used to manage chronic pain. And they do list the strength of recommendations. I will note that physical medicine and rehabilitation is listed on there, as well as integrative therapies and psychological approaches. So our team has been involved in exercise trials more broadly. And so one of the things we were wondering about is what is the role of exercise in helping moderate cancer-related pain? And so we conducted a systematic review and meta-analyses that was published in Supportive Care in Cancer in 2023. This included 76 studies. We did our meta-analysis on only 10 studies because we wanted to include only studies where pain was the primary outcome. And you can see that we did find an effect. So our standard mean difference there was minus 0.73. So we did find that exercise is effective in managing cancer pain. And indeed, other people have published reviews on this. So, went ahead too far. There was another review just recently published in 2024. And this study was, I think this review included more studies and included also randomized controlled trials and observational studies. And you can see these authors, their standardized mean difference was smaller than ours. But in general, both of these reviews support the role of exercise in managing cancer pain. I'll also highlight the integrative oncology guidelines that have been published, and just point out that there is within these guidelines, they do outline the evidence and the strength and quality of the evidence to support various integrative oncology treatments for chronic pain. So they detail very nicely the role of acupuncture, yoga, reflexology, massage, and hypnosis for the various cancer-related pain syndromes. And I also want to highlight in our qualitative research with cancer patients, we have asked them what their views are on the role of non-pharmacological treatments for chronic pain management. And it's important to note that patients are interested in non-pharmacological therapies and they're using them. So as one patient stated, I've tried many, many other ways of reducing my pain. I've tried music therapy, art therapy, yoga, all kinds of other things to see if I could avoid opioid use. Another patient says, well, I find that movement helps a lot for me because I get these spasms and sometimes it's trapped air and sometimes it isn't. So I always walk, and when I'm experiencing, just to see if it might be enough. Another patient says, yoga. I do find that my pain is worse during times of stress. So trying to do something on a regular basis that helps alleviate stress, it helps a little bit. And then finally, one patient stated, I started massaging these two spots that were really painful, that caused a lot of pain. And the pain started subsiding, and now I don't feel it anywhere near as much. It's probably down by 75%. So patients really endorse these non-pharmacological ways of managing their pain. So that was just a very whirlwind overview of chronic pain and chronic pain management guidelines and some of the research that has been done in this area. So to summarize it, what are the clinical practice implications that we need to think about if you're working with chronic pain populations? So hopefully you understand that chronic pain is very different from acute pain. Also that opioids may not be the best choice because there is limited evidence for their efficacy as well as adverse effects. Current clinical practice guidelines emphasize a multimodal approach with pharmacological and non-pharmacological strategies, and addressing overall well-being, functional capabilities, self-management, and psychosocial drivers of pain are paramount. So in the last 5 minutes that I have, I just really want to highlight some of the gaps really in care as well as research. And I'll do that by highlighting where I think some future research areas are. So clearly the role of opioids for chronic pain management, we need more research in this area, starting with definitions of what chronic opioid use is. Also the efficacy of long-term opioids and the harms of long-term opioids. There's very little evidence in the cancer population at the biological, patient, and health system level. There's not really great characterization of chronic pain and cancer. We kind of have that laundry list of chronic pain symptoms, but there's really not good detail around the incidence and prevalence, as you saw. What are the drivers that we need to think about with respect to chronic pain? Are those different in different pain, in different cancer types and different sociodemographic patient characteristics? There's very, very, very little research on the patient perspective of chronic pain, the impacts of chronic pain, and how they want chronic pain to be managed. And then with respect to equity, diversity, and inclusion in cancer populations, this is not well researched at all. We know that in non-cancerous conditions, that chronic pain usually impacts female patients more, and it's also often undertreated more in female patients. However, this really hasn't been researched at all in the cancer population. So if there's any budding keen research in the audience, I would say that's a very good area for you to be involved in. The integrative oncology approaches, including exercise and rehabilitation, we really need more evidence on the efficacy of these approaches. We need to understand what outcomes to measure. So is pain intensity or severity more important to measure than function? Is opioid use an important outcome to measure? So these things, I think, are largely still a black box. And then obviously implementation of chronic pain programs. So in Alberta, where I work, there is a chronic pain program that excludes cancer patients from being participants in that program. So I don't know about other places in Canada. I'd love to hear other people's feedback on that, but we really need to be able to have chronic pain programs available for cancer patients so they can access this multimodal approach. And then finally, we need to think about the role of self-management and the role of psychosocial support, and again, how to integrate those into a multimodal approach for chronic pain management. So in summary, chronic pain impacts a high number of cancer survivors. The treatment of chronic pain requires holistic approaches to address biopsychosocial drivers. Opioids should be used by balancing harm versus benefit and must include patient and family education. And non-pharmacological approaches are promising, but definitely require more research. So thank you for your attention. My contact information is on there if you're interested in connecting with me about this research. And my research is funded by Canadian Institute of Health Research and the Canada Research Chairs Program. And so I think I've left enough time for questions.